Dr. Paul Kuo, and I'm professor of medicine at Stanford. And today we're going to talk a little bit about optimizing clinical pathways to achieve functional cure. And thanks for joining us. So what I thought we would start with would be, how do we define functional cure in patients who have chronic hepatitis B? And what does success look like now in 2026, and how does it differ from our previous endpoints, milestones for those with chronic hepatitis B? So for all of you who take care of people with hepatitis B, as you know, we have historically been treating our hepatitis B patients with nucleoside analog therapies. These are the therapies that inhibit reverse transcriptase and suppress hepatitis B DNA levels. We had first-generation nucleoside analog therapies that suppress virus, but we had to deal with resistance for the first couple of generations of these therapies, that is lamivudine and adefovir. And then we entered a period where, with our current first-line therapies, and these are entecavir as well as tenofovir disoproxil and tenofovir alafenamide, we have outstanding viral suppression rates, very low rates of resistance. But the downside of these therapies is, despite having outstanding viral suppression, and over time you can get almost all subjects who have hepatitis B down to very low or undetectable HBV DNA levels, and this is what is meant by functional cure. Now, this can occur naturally, loss of hepatitis B surface antigen, and it does happen, but at a disappointingly low rate of just 1% per year. In therapy with nucleotide analogs, it's also low, but we're entering an era now where we're able to now see that there are therapies on the horizon that will allow the first increase in our ability to improve functional cure rates. So the goals of functional cure, of course, are to clear surface antigen, ideally make surface antibody. Again, there are multiple clinical benefits from this, and we're going to talk about these right now. One of them is that clearance of surface antigen is associated with additional benefit to reduce the risk of hepatocellular cancer. And worldwide, hepatitis B causes the most hepatocellular carcinoma of any etiology. Oh, sure, MASLD is coming up and will probably be the dominant cause of hepatocellular carcinoma worldwide, but it isn't yet. And right now, hepatitis B still is the driver of hepatocellular carcinoma worldwide. Achieving functional cure reduces that risk substantially by 70 to 80%. And this is a huge milestone, and patients really appreciate that the risk is low. Many of them, the risk becomes much lower. These are individuals who've been enrolled in hepatitis C screening and surveillance programs for years and years. They go get their ultrasounds every 6 months. They go get their blood work every 6 months. And loss of surface antigen reduces that risk dramatically. Of course, depending on age, based on the new AASLD guidance, you can't stop screening these individuals, particularly men after 40, women after age 50, but still the risk is markedly reduced. In addition to the risk of hepatocellular carcinoma, one of the other really important benefits is the loss and the removal of social stigmata that are associated with being hepatitis B surface antigen positive. There's not enough written on this, but for young people who are infected with hepatitis B, knowing that they're carrying around a virus that they can transmit limits their lives considerably. And again, our potent therapies for hepatitis B that are currently approved do an outstanding job of suppressing the HBV DNA. That is, they have undetectable HBV DNA. This translates into far reduced risk of transmission to others, but nonetheless, the surface antigen is still present. Functional cure then allows one to then have the opportunity to withdraw all therapies for hepatitis B if it's done with a medicine, or, of course, if it's done naturally, that's even better. Then the risk of transmitting virus, knowing that you're carrying a virus, is reduced dramatically. And in addition to the medical benefits, you have then individuals who feel like they've been freed from a disease. What about how we pursue therapies to try and achieve functional cure, we are now trending from long-term suppressive therapies. And EASL, European Association for the Study of Liver Disease, actually introduced some guidance strategies to help individuals who have received our nucleoside analog therapies to be able to consider a finite or a truncated duration of therapy. Of course, with pegylated interferon for hepatitis B, it's a finite therapy. It's 48 weeks. And surface antigen rates are actually modest with this. But again, this is one option that's been available to us for years. However, with the nucleotide analogs now, EASL released guidances for e-antigen positive and e-antigen negative individuals. And these guidances are now based on surface antigen levels. And so for e-antigen positive individuals, you should be able to consider stopping therapy. You should clear e-antigen and produce e-antibody. Again, you should consolidate for a minimum of 2 years when you do this. And then you can withdraw therapy and follow patients should you choose to consider this in an e-antigen positive individuals. There are people out there who have their patients achieve seroconversion, and some choose to continue therapy. That is certainly another option. The real interesting topic that has been pursued now in multiple multi-center trials recently is what to do with those who are e-antigen negative. And this is the vast majority of individuals who have chronic hepatitis B. And again, EASL introduced guidance such that individuals who have low surface antigen levels, and these are typically those with surface antigen levels at 100 IUs or less, these are individuals who represent the patient whose immune system has sufficiently controlled the hepatitis B intracellularly, in addition to those individuals who are on nucleotide therapies and have suppressed hepatitis B DNA. And EASL recognized that some of these individuals with low surface antigen who've remained negative for several years can, in a controlled and closely monitored fashion, under the care of individuals who are comfortable managing these individuals, they can withdraw therapy for these individuals. Should you do this, and again, you have to have a sustained period of years of being HBV DNA suppressed, you can follow these individuals closely, that is, those with low surface antigen levels less than 100, or those or in combination with suppressed HBV DNA for several years. Then you follow these individuals, and you'll need to follow the HBV DNA levels and the ALT levels for these individuals every 1 to 2 months for the first 6 months. And then a bit less frequently after that, every 3 months or so for at least a few years. And what you're doing is you are seeing if by withdrawing the nuke, because this threshold of immune response has been achieved, you can then have the immune system come in and clear the hepatitis B. Of course, because you've withdrawn the nucleoside analog, of course, the hepatitis B virus can choose to rebound as well. This is why you must monitor these individuals very, very closely if you pursue this strategy. And that is because the hepatitis B can sometimes rebound more severely or more rapidly than the immune system can actually suppress the virus. And here you could see ALT levels go up to 5 times the upper limit of normal. HBV DNA levels can actually get very, very high. And there you would need to reintroduce nucleotide therapy immediately to prevent a significant flare. In addition, you shouldn't be doing this in individuals who have advanced fibrosis of the liver because they risk decompensation much more significantly. Indeed, the most recent AASLD guidance published last year actually recommended against this stopping strategy with nucleoside analog therapies, and that differs from the EASL guidance. They did list that this is still an option, but they said that the evidence currently doesn't support this strategy. And in my own practice, I have not been withdrawing nucleoside analogs in this manner. Now, There are therapies on the horizon for this. But for now, when you see your hepatitis B patients, once you start, you need to confirm compliance with your therapy. We do this in the first year by checking the HBV DNA every 12 weeks or every 3 months. And I do this not because I'm worried the therapy won't work. We just want to know that the individual who's on the therapy is going to take the medicine. And in the future, should you try other strategies to achieve functional cure, it's another way to assess compliance of the patient as well. In the appropriate individuals, in addition to blood work, and after the first year, I go to every 6 months, we need to screen the appropriate individuals for hepatocellular carcinoma. And again, recent guidance shows this is generally Asian males greater than the age of 40, females also greater than age 50, family history at any age you would screen, African origin, these individuals should be screened earlier in the third decade. And of course, these individuals with cirrhosis also deserve screening for hepatocellular carcinoma regardless of the age of the patient, and those who co-infected with Delta also require screening. So you have to make sure these individuals who are at higher risk for hepatocellular carcinoma indeed can have the appropriate screening for hepatocellular cancer. Then, as we evolve, our biomarkers are going to improve. And I think you will see in the future that quantitative surface antigen is going to be more widespread in its adoption and practice. And we should be able to identify individuals who are candidates not only for novel therapies, such as antisense oligonucleotides in the future, but other combined therapies which will improve our functional cure rates. And so the individuals you see now are going to have a different journey than the individuals who we've been treating for decades. It would be just wonderful if we can address a disease that more than 2 billion people have been exposed to and is a tremendous driver of morbidity, mortality worldwide. And it's hoped that functional cure will allow us to reduce the morbidity and mortality from this global disease. For more information, please go to the CLDF website. There are other wonderful podcasts and other resources available that help tease out this very complex but exciting topic.